Okay, it's 5 o'clock in the UK. Selma, are you ready to start?
Yes.
Great. Okay. So thank you all for joining us this evening. And thank you for joining this webinar, which is about the future of cancer treatments. And we're going to explore the use of CAR T cell therapy and robotic surgery, as these are two innovative approaches that actually can give cancer patients better chances for the best possible outcomes of their disease. My name is Stavroula Chante. I'm an EONS cancer nurse representative, and I work as a lead cancer nurse and advanced clinical practitioner in hematology in the UK, and I'm also a senior lecturer in Oxford Brookes University. And together with me, I have Selma. Selma, do you want to introduce yourself?
Yes, of course. Hello, everyone. My name is Selma Islamčević, and I'm an EONS representative of Croatia. Also, I'm a pediatric cancer nurse, and I work in Zagreb, Croatia. And welcome on our webinar.
Thanks, Selma. So our first speaker is going to talk about CAR T cell therapy. And CAR T cell therapy is a very complex and specialist treatment that has been approved for the use in different types of malignancies. We're going to present to you Dr. Bradley Dixon, who is currently working as a CAR T fellow in the University Hospital Southampton. CAR T therapy is a new service in the Southampton Hospital, and his role is a mixture of inpatient and outpatient care, plus the development of the service and ambulatory pathway. So he's currently undertaking a research project, and he's looking at the immune reconstitution post-CAR T therapy. So he is an expert on the field of CAR T therapy, so he's going to talk to us about CAR T cell therapy, and if Dr. Dixon, if you're ready.
Yeah, hello everyone. Thank you very much. So I will just share my screen and then we will start. Okay, can I just check, is everyone able to see that okay at the moment?
Yes, we can. Thank you.
Lovely. Okay. Yeah, so I've been given the opportunity today to talk about CAR T therapy to you all. So it's a really exciting area of cancer therapy. Has seemingly exploded in the last couple of years, particularly with increasing numbers of indications. And I'm sure people working in oncology nursing will probably have come across patients who have had this therapy or may have looked after patients who's had it. So I was going to talk a little bit today about kind of CAR T, how we got here, what it looks like, what our therapy is, and if we have time at the end, perhaps a little bit about where it's going in the future as well. So disclosures first of all. So what we're hoping to learn today. So I will briefly cover the kind of pathway of how we actually got to giving CAR T therapy, where we move through from various different immunotherapies to get to this stage. And then we'll cover a look at how CAR T therapy works, who is eligible to have this treatment, and finally, what are the complications, which will be a big part of nursing management of patients having CAR T therapy on the inpatient setting particularly. So how did we get here? So looking back through cancer therapy, traditionally we had the three major pillars of cancer therapy. So we had a surgical approach, we had radiotherapy, and we had fairly non-targeted chemotherapy. And these were the main three pillars that we had for a long time as cancer therapy. And then we begin to move through into more targeted therapies. So things like your TKI inhibitors, came about, several decades ago now. And then the evolution of this final fifth pillar of cancer therapy, which is immunotherapy, which is increasingly being utilized across oncology, both hemato-oncology and also solid organ oncology as well. So in terms of the timeline of CAR T therapy, it's been recognized for a long time, the role of the immune system in cancer therapy. Although we've only started to see effective treatments come about in the last few decades, actually as early as the late 1800s, this doctor called Dr. Coley first recognized that by injecting patients who had high-grade malignancies that were rapidly progressing, by injecting bacteria, actually you could induce tumor regression, which was kind of the first clue that we really saw that actually by using the host immune system and by really enabling it to attack the cancer cells more efficiently, you could actually start to show promise where other therapies weren't working. And then that was all we really had coming forward into the middle of the 1960s and the 20th century, where these pioneering doctors, Dr. Eva and George Klein, who were a married couple, they worked on Burkitt cell lymphoma, and they were actually able to show that using immune cells through mouse models, that the host immune system was actually able to recognize and kill cancer cells. At this point, we didn't actually know what the cell was doing in terms of which cell was responsible for this. And then a few years later, it was found actually it was T cells that were the host cells responsible for recognizing and attacking these cancer cells. And then we developed allogeneic stem cell transplants, which have been going on for 50 years now. Really pivotal studies in the 70s demonstrated that actually by using allogeneic stem cells, so stem cells from different donors, they were actually demonstrating T cell activity against the leukemia, which was partly responsible for the remission rates that could be achieved with allogeneic stem cell transplant in the setting of relapsed leukemia patients. And then another few jump forward, another decade or so later, was kind of the first true immunotherapy, which was to use tumor infiltrating lymphocytes by a chap called Steve Rosenberg across in the US. And tumor infiltrating lymphocytes was essentially initially used for things like melanoma, where you would cut out a lump of tumor, and then you would isolate the T cells from that tumor, expand them and reinfuse them into the patient. And they were actually able to treat quite advanced cancer using this approach. But it was fairly limited by the fact you obviously needed to perform surgery and remove cells, and it didn't really achieve lasting remissions in most patients. And then jumping forward into the early 90s, we were first able to generate a CAR, which we'll go on to discuss exactly what that is, which is a chimeric antigen receptor. But they weren't particularly effective, these first generation CARs, and it was more of a theoretical model at that point. But jump forward 10 years later into early 2000s, and we've now developed second generation CARs. And these really did demonstrate really quite exciting anti-leukemia activity. So they were first used in the setting of B, acute lymphoblastic leukemia. But it was another 14 years before we actually got the first approval for a second generation CAR. So in 2017 was when we first had FDA approval to use these exciting new drugs. And how actually does it work? So in essence, we know that T cells are usually able to some extent recognize cancer cells and recognize these as something which needs to be targeted to be destroyed. But the way in which cancer cells work, one of their hallmarks is that they evade the immune system through a series of mechanisms. Sometimes it can be through reduced antigen expression. Sometimes it can be through deliberately dampening down the host immune system. So the T cells that would otherwise be attacking the cancer are unable to do their job. And what CAR T therapy looks to do in essence is to try and supercharge those T cells so that they're actually able to recognize the cancer cells and kill them as they would normally try to do. And you can see here on the cartoon on the right hand side, you're essentially adding in a new receptor molecule onto the patient's T cells so that they can more effectively target the cancer cells. So this diagram shows a little bit about a simplified structure of what a CAR T receptor actually looks like. So this is quite different from a normal T cell receptor. You can see at the bottom in the what's called the endo domain that you've got the co-stimulatory molecules. So this is something which is newly added to the second generation CAR products, which is what we are currently using. So all currently licensed CAR T products are second generation CAR T products. And these really help to improve how long the CAR T cells survive. So when we infuse CAR T cells into a patient, we can now expect these cells to survive for anywhere of 6 months up to possibly years in some patients. But the key in terms of recognizing the tumor is that what are you actually targeting? So we're targeting something called CD19. So CD19 is an antigen which is found on the outside of mostly B cells. And this is found on both healthy B cells, but also malignant B cells. So it's quite a widely expressed antigen. But with the CAR T receptor, it's primed to recognize this target, and upon recognizing this target antigen on the B cells, it induces the T cell to essentially kill that particular cell. So you can see it's going to be killing not just tumor cells, but also healthy B cells. So this is a little kind of scheme looking at the process of how we develop a CAR T cell. So first thing that's important to note is if you think of it as similar to other type of adoptive cell therapies, so allogeneic stem cell transplant or autologous stem cell transplant, you first of all have to harvest a product. This is a live drug essentially. And in this particular case, you're harvesting the T cells. So you're not harvesting stem cells as you would with an autologous stem cell transplant. You're selecting out the T cells. Depending which type of CAR T product you're using, that either happens by the bedside or it may happen in the laboratory. But essentially, you're collecting the blood through what's called apheresis or leukapheresis. And then they get sent off to a laboratory. So in the UK, we send a lot of ours off to the Netherlands, but the US is a major manufacturing site as well. And here they use usually a viral vector. So you're introducing a virus to the T cells. This is a virus which is inactivated, so it's not able to cause disease in the patient, but it does introduce a new genetic construct. So you add on this new receptor called the CAR T receptor. And when you've added that to the T cells, you then have to multiply the T cells. So you want to expand that population. So you've got a really good supply when you reinfuse the patient. And then you reinfuse, roughly it's about a 3 to 4 week turnaround. So when they first did the trials, they were able to do it faster than this, as is usually the case. They were looking at 11 days or under, but actually real world data, certainly in the UK, is you're looking at about 3 to 4 weeks. So the vein to vein time is from original apheresis of the T cells from the patient and then to reinfusing. However, you can imagine that with patients who have advanced disease, and for most patients who are receiving this therapy, they have got refractory or relapsed disease. 3 to 4 weeks is quite a long time for someone who may have a very rapidly growing tumor. So you need to do something in the meantime while you're waiting to be able to use these cells. And for that, we use something called bridging therapy. Now, bridging therapy is exactly that. You are essentially trying to keep the patient as well as possible and alive so that they are able to have their CAR T cells that month or so later. And when we initially started using CAR T therapy, this was actually quite an issue, that a lot of patients were really deteriorating by the time you got to the point of wanting to infuse the cells. Their performance status, their functional ability had really dropped down. So this is really integral, and this is an area that we've started to make quite good improvements in. So we usually have 3 options. Kind of in the UK and in Europe, we tend to use chemotherapy or sometimes radiotherapy or a combination of both. The kind of chemotherapy regimes we use obviously depends on what the underlying disease is and what previous treatment they've had. But usually, for example, for high-grade lymphoma, we use regimes like rituximab, bendamustine, and polatuzumab. Radiotherapy useful if there's localized disease. In the US, they tend to be more likely to use just steroids, but that's partly because they tend to have a faster turnaround time. So they can usually get from apheresis to cell infusion is usually 2 weeks. So with such a short turnaround, you can get away with using steroids. So from the patient journey perspective, so usually the CAR T cells are delivered in a specialist center. So usually it's a center that also does allogeneic or autologous stem cell transplant. So they will be referred in from a local hospital usually. And then the first thing you need to do is assess, is this patient eligible? So that's a couple of questions. You're looking at what is the fitness of the patient? And actually for CAR T therapy, you don't need to be as fit as we used to think you need to be. So generally we would look at ECOG performance status of even up to 2. You can actually give this therapy for. So potentially patients who are not fit enough to have an autologous stem cell transplant might be considered fit enough to have CAR T therapy. And that's quite important to remember, that this is quite unusual for a new and exciting therapy like this, so that it's available for such a wide spectrum of patients. And things like age, there is no upper age limit for who is eligible for CAR T therapy. So we've done CAR T therapy on people in their 80s. So really quite a wide range of patients are eligible to have this treatment. And then, of course, do they meet the criteria? So in the UK, that's quite strict in terms of have they got the right disease? Have they had the correct treatment as a licensing agreement? So that's usually done in clinic, and that needs to be done pretty promptly so that you can get the ball rolling. Then you go through to apheresis, as we've discussed, and bridging therapy. And then you get your cells back, but then before you can give your cells, the next important step is something called lymphodepletion. Now, essentially what you're doing with lymphodepletion is you're trying to clear out an immunological space so that you can give the CAR T. So if you, when the first trials, when we gave patients CAR T therapy without lymphodepletion, we found that the CAR T cells on infusion, they tended to die out quite quickly. And so the impact or the benefit for the patient was quite short-lived as well. And actually lymphodepletion helps to create that immunological niche in which you can infuse the patient. It's a bit like conditioning chemotherapy that you'd use for an autologous stem cell transplant. And that tends to be a fludarabine or cyclophosphamide combination of the two regime, delivered usually over 3 to 5 days. So the point of lymphodepletion is the point of an inpatient admission. And then cell infusion happens roughly about 5 days after that. So we'll briefly talk about outcomes. There's obviously a range of diseases that CAR T therapy can be used for, so we're not going to go into all of those different diseases, but just to briefly look through, it's a complete response rate, which is by definition, in lymphoma perspective, that means that you've eradicated any signs of active disease, so whether that's a PET scan or a CT scan. And you can see that the complete response rate is really, really encouraging for these patients. So to give this some kind of perspective, this is what you're looking at. So 7% would be the previous response rate with the best previous standard of care. So if you're looking at third line treatment for aggressive B-cell lymphoma, so these patients have probably had something like R-CHOP up front, and then they've probably had second line therapy with salvage chemotherapy and an autologous stem cell transplant. Those patients previously, the best you could hope for was about 7% complete response rate with third line therapy. And we're now looking at between 40 to 54%. So huge improvements in terms of complete response rate. And this is broadly applicable across multiple diseases. So not just high-grade B-cell lymphoma, but indolent B-cell lymphomas, B acute lymphoblastic leukemia, multiple myeloma. So really, really encouraging. But does this last? So we know that you can get a really good initial response to CAR T therapy. How long does that continue for? So these are Kaplan-Meier curves, which you may have seen before, which essentially looks at tracks patients over time, tracks a cohort of patients, and looks at their outcomes. So progression-free survival, which is defined as no increase in the burden of tumor based on scans usually, or CT or PET scan imaging. So progression-free survival, you can see the same as with overall survival on the graph below, that the graph begins to plateau here. Now, what that means is when you see a plateau on a graph like this, that tends to indicate that the patients who have reached that stage and haven't progressed, they are likely to continue with that good outcome. So the patients here, if you look, it's around about 45 to 50% the progression-free survival, and that extends at the 12-month point. And you can see the graph is flat after that, which indicates, although we don't have quite the long-term data yet, that would suggest that if you make it to 12 months and you haven't progressed having had CAR T therapy, the chances are you will stay and not have further progression, which is really exciting and really quite different from what you would see with a normal chemotherapy survival curve, which tends to continue to trend down to zero, indicating that people tend to relapse at various time points after treatment. And again, in the bottom right, if you just compare, so in third line relapsed or refractory diffuse large B-cell lymphoma, with previous best standard of care, the median overall survival was just over 6 months, so really quite dismal. With CAR T therapy, you're looking at over 19 months, so pretty much trebling the median overall survival in third line setting. So really, really exciting and really changing the whole landscape for what we previously were able to offer patients in this setting. So who can have it? You may have seen, if you've worked in centres with CAR T therapy, that the indications for CAR T, or the licensed indications, are continually expanding. So back in 2017, it was first only licensed for patients who had relapse refractory B-ALL under the age of 25 years, or for third line large B-cell lymphomas. And then only a few years later, in 2018, it was also extended to be adults with relapsed acute lymphoblastic leukemia and also mantle cell lymphoma. And then in the last year or two, that's now also included second line large B-cell lymphoma. And you can imagine the number of patients that we are potentially eligible to treat is increasing dramatically, which is very exciting, but also brings the difficulties of financial, how do we physically cost for all these things, and how do we admit enough patients? And myeloma, there are licensed treatments for myeloma with CAR-T, but it hasn't really taken off quite as much yet. It's still mainly kind of in the trial setting, but if we start using CAR-T therapy for patients with myeloma, that's a huge number, because that's obviously a much more prevalent disease than these rarer leukemias. So basically increasing. It's mainly for high-grade lymphomas, some indolent lymphomas, and some leukemias. So complications. So there are complications. We are getting better at managing them. I think it's important to say, when we first started giving CAR-T therapy, there were really some quite dramatic ITU admission rates, looking at 50–60% of patients admitted to intensive care, but we are much better, and the percentages are falling all the time. So we can divide up complications into short-term and longer-term. So in the short term, we have CRS, or cytokine release syndrome, and ICANS, which essentially is neurological toxicity. It stands for immune effector cell associated neurotoxicity syndrome. In the longer term, we have B-cell aplasia. Now, as we said earlier, CD19 directed CAR-T therapy will wipe out not just your tumor cells, but also your healthy B cells. And that is a real issue going forward for these patients. And then straddling the two, you have infectious risk, and you have cytopenias as well. And we'll talk a little bit more about those. So first of all, cytokine release syndrome. So this is probably the one that people worry about the most. So cytokine release syndrome essentially is a storm of cytokines. So when you have these CAR-T cells infused, they are recognizing the target tumor cell, and the response to that is to release huge numbers of chemical cytokines, which are the chemicals in the body which tell your body that something's going on, there's an inflammatory process, and your body responds to that. So the hallmark features of this is a fever, often high fever, up to the mid 39 degrees, with hypotension and hypoxia. The chart on the right is fairly wordy, and I'm not expecting you to remember all of that, but it's probably best to sum it up that it can affect pretty much every organ system in the body. So it's a spectrum of disease progressing from initially simple fevers, running through into potentially multi-organ involvement, and it can be life-threatening. But we are getting better at managing it, and we tend to jump in earlier now, so we are less likely to see this kind of more severe spectrum. So the mechanism of cytokine release syndrome, as I've touched upon, essentially you're getting this overwhelming release of inflammatory cytokines, and they drive all of the subsequent problems. And the grading, just like with ICANS, we grade it from 1 to 4 essentially. So grade 1 is fever and constitutional symptoms. So patients feel really beaten up. They feel like they've had a really bad flu or sepsis essentially, muscle aches and pains, high temperatures, just want to sleep most of the day. And most patients experience those kind of symptoms. And then the higher grade begin to develop problems with hypotension and with hypoxia. Initially, if that's just hypotension, which can respond to fluids or oxygen requirement of under 6 liters, we would call that grade 2. And when you start to get more significant hypoxia or hypotension, which is requiring intensive care support to support blood pressure, that would be grade 3. And what we essentially want to do when we're treating patients who have toxicity from CAR-T therapy is we want to keep it in these lower grade systems, which are not likely to cause long-term damage. We don't want patients to get to the stage where they're needing intensive care with grade 3, 4. All you really need to take from this graph is look at the timing of it. So the cytokine release curve, as you can see on the bottom part of the graphs, on the third line at the bottom, you get this early release of cytokines. So this is in the first couple of days, you get this huge increase number. And this actually precedes when you start to see the CAR-T cells increasing. So not only do you expand the CAR-T cells before infusion into the patient, when they are infused into the patient and they recognize the tumor, they will also rapidly increase in number as well. But the ICANS curve tends to follow afterwards. So CRS tends to come first. And this is a grading system which we've already talked about. I won't labor the point on that. In terms of management, it's a moving kind of paradigm depending how severe the disease is. But we start off with paracetamol and supportive care. Really important to stress, we must assume that there is an infection on board. So these patients will be neutropenic, and we can't tell whether this is infection or whether this is cytokine release because the symptoms are very similar. So we treat always with antibiotics. And then tocilizumab is essentially it's an IL-6 blocker, so it's a drug that helps to dampen down this inflammatory response. So we can give this, and very quickly we can see improvement in patients' symptoms, but we only really give that for patients with grade 2 or greater cytokine release. Moving forward, we then have steroids, which can be used if tocilizumab doesn't work, and these doses are pretty high, so 40 milligrams of dexamethasone a day, and if that doesn't work, you're looking up to pulsed methylprednisolone at really high doses, and we want to try and avoid getting to the ITU stage, which is later on. So I think we've mainly covered this, but just to say, the onset of cytokine release syndrome is really quite quickly. So it happens within a couple of days of therapy, and up to 85% of patients will get it. So it's really common. ICANS, so this is the neurological toxicity. Essentially, the neurological toxicity is a similar process. So these inflammatory cytokines that have been released, but we think that in this case, the reason why you get disrupted confusion and thoughts is because of the disrupted blood-brain barrier. So all of these inflammatory cytokines, they can get into the circulating system and then through the blood-brain barrier, and it causes the symptoms which we'll talk about. So that's the same graph we showed previously. So ICANS follows on from CRS. So there's a scoring system called the I-score, which we use to grade someone with neurological toxicity, and it's a fairly standardized questionnaire which the patient is asked at multiple points throughout the day, and then we can develop a score from that. The higher the score, the higher the I-score, the better. So the lower the score, the worse the patient is. And we can grade the ICANS scoring from 1 to 4, sorry, just as we do with cytokine release syndrome. Starting off with quite subtle symptoms. So the initial symptoms might be confusion, difficulty with speech, and disorientation, and then progressing through into seizures, which we really want to avoid. And the worst outcome is to have life-threatening refractory seizures or coma. So we definitely do not want patients getting to grade 4. So early prompt treatment can help to prevent us getting that bad. This is just an example of what the handwriting looks like and how quickly it can change. So really quickly you see in the space of 1 day that the patient's handwriting becomes completely illegible, unable to stay within the lines. And this is quite a common pattern that we see. Management is slightly different than it is with cytokine release. We don't use tocilizumab, but we do use steroids, and that is our mainstay of treatment. We do consider other investigations as well to rule out other causes like infectious signs, encephalitis. So we might want to do a lumbar puncture and an MRI scan, and ultimately ITU support if the patient is progressing despite early phase treatment. And the onset time, so you're looking at about 7 to 10 days for ICANS. So it tends to follow after cytokine release syndrome. So we're coming to the end of time. So just to round up, we've covered the short-term complications from CAR T therapy, but the longer-term management. So once they leave hospital, there are still issues. Cytopenias are really common. So we see a lot of patients after treatment who have these prolonged cytopenias, and they can be really quite fluctuant. So regular blood test follow-up and kind of specialist nurse support is really helpful to help manage this with GCSF or blood or platelet transfusions. Late infections are an issue, and that's both a combination of neutropenia, but also disrupted T cell and B cell function. And patients may be eligible for immunoglobulin replacement. So B cell aplasia, you're not able to produce antibodies. So getting patients on a regular immunoglobulin regime can help to ameliorate the worst risk of infection from that. And then finally, there is an extended neurological window. So some patients will get neurological toxicity months after treatment, but this is exceedingly rare, but it's always just worth keeping in mind if you're seeing these patients many months after treatment. And then finally, relapse of disease, of course, is an issue. So they'll have regular PET CT scans usually in the first few months afterwards, and continuing rehabilitation. So it wipes patients out. So 4 weeks, 5 weeks in hospital, a lot of it potentially spent in bed. Really needs to continue to build up that strength over many months after treatment. I will stop there because I've run a little bit over time, but I've got time for questions as well if we don't mind running over a little bit.
Thank you very, very much, Dr. Dixon, for covering this subject. And you explaining it actually very simply for us to all understand. I do have a couple of questions in the chat, if that's okay with you.
Absolutely.
So one of them is like, in terms of manufacture, how do we move to shorten the time from apheresis to production? And would this improve patient outcomes?
Yeah, that's a brilliant question. So there's a couple of ways we could look at doing that. So one exciting area potentially is to use what we call off-the-shelf or allogeneic CAR therapy. So currently it's autologous, so it's a patient's own T cells that we've harvested that we then have to send off to be manufactured and to reinfuse. But actually, there's a school of thought that we could use donor T cells, which are already pre-made and created with a CAR product. So then you would have the risk of potentially things like graft versus host disease, but actually you've got these cells up front ready to go, and then you won't need to wait for 3 or 4 weeks. You can basically infuse as soon as you found out that the patient is eligible. So that's an exciting area that is currently being worked on quite a lot. Outside of that, there are things like supply chains are mainly the limiting factor. So the actual manufacturing isn't too much of an issue. We can do that quite quickly. It's usually the supply chain which takes longer to sort. So I think off-the-shelf CAR T is more likely to be an improvement factor.
Great, thank you. Another one, is there any evidence exploring whether we see differing outcomes from CAR T in subpopulations, particularly in people with African heritage, as we know that there is greater genetic diversity?
That's a really good question. I don't actually know the answer to that. Certainly not about ethnicity. The initial trials were, as with most clinical trials, tended to be more restrictive in who they allowed to kind of be eligible. But actually the real world data that we're starting to see coming through with obviously much greater numbers, as I mentioned earlier, we're doing it on a whole variety of ages. We're doing it on patients with widespread disease who potentially weren't eligible previously. So I think we will start to have that data coming through. There's a bit of an issue in terms of, to get CAR T therapy, you need to be able to travel to a referral center, which can be expensive. And sometimes socioeconomic factors mean that some ethnicities might not be able to make that if they tend to have, don't live in the cities that have those kind of CAR T centers. So that is probably data we will start to see in the coming years, but I don't know, is the honest answer.
Sure, thank you. And if you have another minute, there's another question that came
Yeah, no,
up.
of course. Yeah.
Thank you. Could you tell us a bit more about CAR T in other tumor types out of hematology? Any trials or any results that you are aware of?
So there aren't any current active trials that I'm aware of that are at later phase trials. So TILs, or tumor infiltrating lymphocytes, there are lots of trials to that, but that's not actually involving a modification to the T cell. In theory, CAR T cells can work in other tumor types because you can change what the target antigen is and use that in other tumors. Part of the challenge that you have is that solid tumors tend to have a different tumor microenvironment, which makes it more difficult for CAR T cells to actually penetrate through that. So they secrete basically an anti-inflammatory kind of soup around those tumors, which makes it really difficult for infused T cells to get to the right place to attack the tumor. So we are looking at things like there's a fourth generation CAR construct called armored CAR, or trucks they're called, where you actually combine the CAR T cell with a pro-inflammatory protein essentially, and that can help to cut through the environment around a solid tumor. So in theory, those kind of treatments could be used for solid organ tumors, but I think we're probably a decade or more away from seeing that in practice.
Great, excellent. Can I ask the last one, please?
Of course you can, yeah.
Thank you. Do steroids have any impact on the long-term effectiveness of CAR T?
Yes, another brilliant question. We thought they would. So when we first started using CAR T therapy, in theory, if you give someone steroids, it will reduce the expansion of the T cells, and that is the exact opposite of what you want with CAR T therapy. What we're starting to see actually with the real world data is that providing you're using steroids judiciously, there appears to be no difference in the response rates of the patients who have received steroids versus those who haven't. But the caveat to that, I would say, is that very early use of steroids, so steroids in the first few days before you get that expansion of the T cells, is much more likely to be an issue. So we do not give things like hydrocortisone as a pre-medication prior to CAR T for that reason. But yes, providing it's given appropriately, so probably 5-6 days or later, it doesn't seem to have any impact on how well the CAR T works.
Great. Thank you so much.
You're
Thank
very
you for
welcome.
coming. That was a brilliant session. You're fun from us. Thank you so much. I know you're busy. Selma, I'm going to pass on to yourself.
Thank you for having me.
Thank you,
Thank
Dr.
you.
Dixon.
Thank you. Can you hear me all?
Yes, great.
Okay. Hello once again. Here's time for our next presentation. So our second speaker is Danko Kostadinov, and he's going to present you his working experiences with robotic surgery. He's a surgeon originally from Sofia, Bulgaria, and during his career, he received several scholarships abroad in the UK and in the USA. And now he works as a general surgeon at King's College Hospital in the UK. Danko, here you go. We are looking forward to hear what you have to show us and present us.
Hello, everyone. Thanks for having me tonight. And as Selma said, I'm just going to speak briefly about a robotic surgery, and is there any field in that area around the oncological surgery? So I presume, just quickly to ask, you can see the slides? So I have nothing to disclose, and as Selma already mentioned, I'm originally from Bulgaria, but for the past few years, I'm working in King's College, and my job is shared between the two hospitals, which actually is quite entertaining, because sometimes you can even have the opportunity to treat some Royal Highnesses. Anyway, I'm a colorectal surgeon, and what a colorectal surgeon actually is doing is to treat mainly the cancer of the colon, rectum, and the anus. And for me, that's quite an entertaining bit, mainly because we're fighting for cancers, and every bowel cancer is different, which is quite challenging sometimes. But before we started talking about the robotic surgery, I think we need to do a little bit of a time travel. And as you can see here, we need to go backwards before we go into the future. And you cannot learn how to fly just by going and trying to fly. You need to learn first to walk, you need to climb, you need to dance. And it's exactly the same like in surgery, because you cannot start with the robotic surgery strength from the beginning without knowing the basis. And none of this, as you can see, this is the laparoscopic surgery or even the robotic surgery will be actually available if you don't know how to operate in an open surgery. And open surgery usually is being maintained by making a big incision, which means big incision, a big surgery. But for the past 3-4 decades, that idea has been changed dramatically, and the less invasive, the better. But before I started, I need to mention a few of the pioneers of the open surgery, without whom nothing of the current surgical experience will be available, as well as people that have managed to invent lots and lots of devices that are helping the surgeons in their everyday life and work. So just briefly, how is actually the robotic surgery being maintained is by starting through what is called the surgery of the natural orifices. And this gentleman here, Professor Gerhard Bues from Germany, managed to invent an idea of operating of rectal polyps transanally. And that's what actually made the pioneering in that field, that the smaller operations or the laparoscopic operations can be implemented in bigger surgeries. In UK, one of the pioneers or the father of the laparoscopic surgery is Sir Alfred Cuschieri. Anyway, for surgeons, everything is a game, and we're really entertained when we're doing it. And whether you're doing it as an open laparoscopic or robotic way, there are different aspects that you need to mention, mainly which are in between the tactile feeling, which you have in the open surgery, which in the laparoscopic surgery is been decreased, but not completely lost, going into the robotic surgery where the visualization is much, much better, but you have no tactile feeling. Just very briefly, how is the laparoscopic surgery being maintained? As you can see here, whether you're operating on the left-hand side or on the right-hand side of the body, it's always about triangulation and setup. So the assistant, the surgeon, the camera, and the instruments needs to be on the same area, directly towards the target that you want to remove. For example, in a right hemicolectomy, you need to set up 4 different ports attacking the area that you want to remove. And in this case, we need to remove, for example, the right colon. This is how I'm teaching my trainees when they're starting an operation, they need to position and make a diagram, what they need to remove and which are the main steps. Most importantly, you need to perform what is called an oncological operation, which means that you need to give the patients the best possible outcome ever. And in the way that you're doing it with the laparoscope, it's always minimally invasive comparing to the open surgery. And the main benefit, for example, from the laparoscopic point is less pain, less tissue injury, less scarring, and it's more precise and safety when we're talking about bleeding, for example. But there's always a learning curve, so you cannot just start and fly, as I've mentioned. You need to learn how to do it. And between I can't and trust me, I'm an expert, there's a learning curve. We all want that learning curve will be like this, but the reality is that the learning curve is actually much more steep. You have slow, you need to have patience, you need to have a good mentor, you need to have people to help you until you're actually proficient, and then the plateau will come. And as one of my professors would like to say, decisions are always much more important than incisions. And in patient safety, I think that's one of the most important bits. As you can see, there is not much of a difference in relation with the survival probability in between open and laparoscopic surgery. But we're not here to talk about this, we're talking about robotic surgery. So what is that really a robot? No, it's not. It's a setup. So you have a robot, you have a console. And as you can see here, the surgeon on the left-hand side is sitting on the console and the robot is actually into the patient. So the surgeon is doing the operation remotely. And you can be anywhere in the world. But I'm not here to promote only one robot because there are different consoles. And as I said, there's no disclosures. So as you can see, there are different types of robot in different machines. What are the benefits? So faster recovery, greater precision, better screening, reduce of infections, but all of those actually benefits are the same as the laparoscopic surgery. So what is the main difference? And as you can see here in this diagram, there are a few bits and pieces that I would like to point your attention towards. And first of all, that's where the surgeon sits. So in the laparoscope, you need to be immediately next to the patient. During the robot, you cannot be not even in the room, you can be in a different country. Second, how is the level of dexterity? The main difference is that if you're having, for example, a tremor or some problems, the robot will remove that as it's an AI integrated into the console. And the third and most important bit is that it gives you a really nice access to the heart in very difficult reaching places, which I think is the main benefit between the robot and the laparoscope. If you're comparing the robot versus a human, for example, you can see that there's a certain areas that you can also point towards, especially from the human perspective. You have the dexterous feeling and the tactile feeling, which is the most important bit. Sometimes that is what is needed in the robot, in order to distinguish where a certain tumor or a certain lymph node is, which is lacking in the robot. Anyway, practically, in my opinion, there are 5 main benefits. First of all, is to reaching a very limited spaces. Second is that this tremor of your hand will be completely removed. Third is that you can be anywhere, literally anywhere in the world. If you have a good internet, there won't be any problems to do a robotic surgery. But the most important bit is then you're the one to have the control. So there's no assistant, there's no one else that you can blame. So it's only you. The disadvantages on the other side is mainly that you still need an assistant, as the console up to now doesn't have, any of the consoles doesn't have a suction irrigation into the console, which means that you still need another port, which is a laparoscopic port, in order for your assistant to help you. And not to forget that it's quite an expensive maneuvering. So practically that's how a setup looks like. You have the patient on one side, you have the surgeon on the other, and they're working on the console. You have the view, so everyone in the room can see what is happening. But how are you setting up that console, and how from that space is becoming that limited space? And in the end, how you can maintain a really good triangulation inside. As you can see, it's very similar to the laparoscopic ports, but they're slightly bigger. The idea is that you can position anywhere the ports, which can maintain and give you a really nice triangulation, because the main difference between laparoscopic and robotic surgery is that inside the body, you have a 360 degrees flexibility. So as you can see here in those diagrams, there is absolutely no differences between doing an extracorporeal anastomosis if you're performing a bowel surgery, or an intracorporeal anastomosis. Mainly, the only difference is that you need to perform a slightly bigger incision in order to take the specimen out. Anyway, the robot is also not easy to learn. And as you can see here, that's a completely different aspect when you need to learn starting from the scratch. And if you see how many days after the first surgery you need to become a proficient and limited, your operative time is actually quite a lot. But when we're talking about small spaces, how small is a small? As you can see here, this is 1 penny, and this is how big the robotic arm is. And I would like to show you a small video, practically, which will give you an idea how you can maintain a small space. And in this case scenario, a colleague of mine has maintained that video and sent it to me as I asked him. It's a small grape, and the robot is practically suturing that small grape. So you can have, I think in this way, you can have a better idea how precise the robotic surgery can be. And this is a 5-0 stitch, which is usually a very, very tiny one. And has been used by the vascular surgeons and the cardiac surgeons. So it's a really, really precise maneuvering. And as you can see, the main difference between robotic surgery and the laparoscopic surgery is mainly in the 360-degree rotation inside the patient. The biggest disadvantage is to learn how much tension and traction you need to put, because you have no tactile feeling. So it's very easy, you can break whether the thread or the tissue inside the patient, and sometimes that can have a devastated consequences. Yeah, it's cool. It's a nice maneuvering. I really like it. It's very entertaining, but as I'm saying, it's a different learning curve, and it's a completely different ball game from the modern surgery. As you can see, it's been done inside a bottle. And once again, I'm not promoting the Da Vinci's robotic stack. It's practically because it's the most famous one and the most widely used. Anyway, surgery for me, it's an art. And as you can see, practically, it's always been performed in the best benefit of the patient. But yeah, we're all like new toys when they're coming. But let's not forget that it's a teamwork. And I would really like to use the opportunity to congratulate my colleagues from my oncology nursing department who managed to win the award last week. They're really, really nice. And in the end, the most important thing that we need to think about is the patient, because it doesn't matter whether you're doing a laparoscopic, open, or robotic surgery. As you can see on those diagrams, the survival probability or the disease-free survival time is absolutely no change, whether you're proficient in open, lab, or robotic surgery. And as I mentioned, decisions are much more important than incisions. So when my advice for anyone who would like to go and do whether lab or robotic surgery will be to plan your cases and start with the small cases in the beginning and gradually becoming more and more proficient in doing that. And in the end, I would like to say that it doesn't matter whether you're doing a proficient surgery, open, lab, or robotic. The most important thing is to do the accurate operation. As you can see here, this is a difference in survival rate in between doing an oncological R0 resection with complete nodal clearance versus no. And you can see that there's a significant difference. But is the robot actually having the infinitive power as we're expecting? And the answer is no. This has a few cases that has a complications after open and robotic surgery that the robot cannot help you, because I think they're too big and too complicated for it. Or if you need to remove more than one organ, like in this case, we have a left-sided colon cancer with a huge metastasis into the ovary. And I think there was a very brief summary of how the robotic surgery looks like. So I would like to say thank you for your attention, and I'm very happy to take any questions.
Thank you so much for your presentation. I will be honest, I didn't have any clue about robotic surgery, so it was really great, especially the video. We will wait, maybe someone will have a question in our chat. And can you tell me who is actually a candidate for robotic surgery when we are talking about patients?
So anyone can be a candidate for robotic surgeries, and as with the open and the laparoscopic surgery, there are certain limitations. So as I said, if you're an expert and be proficient in any surgery, you just need to plan things ahead. The main advantage of the robotic surgery is, yes, it gives you the more flexibility. I personally think in my area of expertise, which is the colorectal surgery, doing a robotic surgery is only indicated into the rectal cancer, because anything else is just a show off. From my perspective, there is no difference whether you can perform robotic or lap surgery, because it's exactly the same instruments. You're using like 3, 4, 5 ports. The ports in robotic surgery is with 5 millimeter bigger, which on the other hand is increasing the risk of post-operative hernias, increasing the risk of having an infection. So I don't see any much of a benefit doing robotic in left or right-sided colon cancers, but definitely in the rectal cancer, especially in male pelvis. I think that there is not a better surgery than the robotic one. Obviously, the limitations probably are coming from the case itself. Like if it's too advanced, lacking of tactile feeling will may lead you to doing an R1 resections and worse oncological outcomes. But I cannot see any other limitations rather than, as I said, similar to the laparoscopic ones.
And when we are talking about recovery and hospital stay, what's the sum?
So it's exactly the same recovery. I mean, I think the companies are promoting the fact that the robotic surgery is much faster recovery, less complications, less bleeding, which I don't really see it in my practice, and I don't think that anyone can prove it. Because as I said, the difference between lap and robotic surgery is mainly into this triangulation that you're having inside the patient. So the difference between open and lap is that you cannot feel anything with your hands, and your instrument in the laparoscopic surgery is straight. You don't have the flexibility inside, which the robotic surgery is giving you. But as I'm saying, I don't think that with the whole ERAS protocols that have been implemented into UK and many of the other European countries, I don't think that there is that dramatic difference. Yes, the only thing that you're limiting is the trauma on the abdominal wall. You're making a minimal invasive surgery, which will reduce the post-operative infection, and it will speed up your recovery. But I don't think there's that dramatic difference between lap and robotic.
Okay, thank you. We have one question in our chat. Have you seen any increases in pulmonary embolism with robotic surgery?
I think the increase in the pulmonary embolism is mainly in relation with the BMI and the patient's comorbidities rather than with the surgery itself. Because as I'm saying, I don't think that robotic surgeons at the moment are doing complex cases and very, very obese patients laparoscopic. Yes, it's much easier if you have an obese patient to try to do it lap because you're minimizing the abdominal wall trauma. But on the other hand, sometimes it's very, very misleading when you're operating on them. So in relation with the DVT and the PE, if you're not proficient, yes, the prolonged operative time until you reach the plateau or like the curve of proficiency might increase that. But if you're having a mentor who will help you and guide you like a proctor once you're starting doing the robotic or the lap surgery, I think those things are same as in the open surgery.
Okay, thanks. Stavroula, you have a question.
Yeah, I do. Thank you. I'm from experience. I work in the UK myself and in West Midlands, and we don't like for our hospital. We have the equipment, we have the staff, but the staff have not undergone particular training as yet. So we cannot use the equipment because the staff have not been trained. So is there a specific like training, like national training, maybe in the UK or anywhere in Europe that you know of that is needed? Or is this completely between like, I don't know, somebody within your hospital who is training you and then you just pass all the training to somebody else?
So here we're opening like the door of the different companies. So if we're talking, for example, about Da Vinci, which is the intuitive platform, and it's the most widely used because that was the first one. When your hospital make like a plan to build up a robotic center, usually they need to find out which platform will suit their surgeons better. If you go, because our hospital went into intuitive, and I can tell you how it goes in general, is that intuitive themselves need to certify you as a surgeon, which means that there's a certain training program, which is usually a simulation based. So every surgeon needs to perform at least 80 to 100 hours simulation, which doesn't have anything in common with the real life. It's usually a 3D objects that you need to remove some like cones or rings and put them from one place to another, opening like drawers and putting things inside, outside, until you became proficient how the whole console works. Because as I said, it's very much different from the laparoscope, because you're not only using your hands, but you're also using your fingers in rotating, in like catching things, etc. Then when you start on real patients, you need to have a proctor who is a certified proctor that needs to come and do the operations together with you. Ideally, as I'm saying, ideally in an ideal world, you need to have two consoles which are working at the same time. So on one of the consoles will be the proctor, and on the other consoles will be the trainee. And in this case, it's not a trainee like a junior doctors. It can be a trainee consultant who is proficient in laparoscopic and open surgery, but has no experience in robotic surgery. So yes, unfortunately, there is no national certification, but there is a local one, which is usually in between the ethical committees and the safety committees of the hospitals.
Thank you. And if you don't mind me asking another one, so how long you would say that these 80 or 100 hours that you just mentioned, how long does it take for somebody to be trained if they start, like intensively?
So it's funny because they're like back in the days, maybe like 15, 20 years, there was a trial done in States where they give little childs, like teenagers, the opportunity to perform a laparoscopic surgery on a simulator. And then they compare the outcomes when they explain them what they need to do, and they compare their outcomes to the certified laparoscopic surgeons. So in the end, it turns out that the outcomes are pretty much similar, which means that it all depends on how your brain and how your training is. I think the new generation is more open for the new equipment, for the new like robotic and AI type of based equipments. I think if you're pretty much experienced in laparoscopic surgery and you like know what you're doing, the transition between laparoscopic and robot is not that difficult. But if you're like, as I'm saying, the pioneers or the dinosaurs in surgery, which majority of your cases are done open, and you're struggling to perform a laparoscopic surgery, is going to be a disaster for you to learn how to do the platform.
Thank you.
We have one question, if you don't mind. It says, in the UK, robotic surgery has been used for CRT and urological surgeries, but not sure for complex operations as pelvic extraction. What is your opinion?
Yeah, it's so mainly there are certain centers in UK that are performing robotic surgeries, and I think that the main benefit, as I've mentioned, is mainly into the pelvic area. So the gynecologists are doing lots and lots of procedures. The urologists, like I think that robotic prostatectomy is going to be a golden standard for them anytime soon, if it's not up to now. But the complex exenterations, it's a little bit more problematic. And the main problem, in my opinion, comes from the fact that the exenterations are usually performed for very advanced cancers. In those cancers, the lacking of the tactile feeling when you're removing the cancer tissue makes things very, very difficult. As I've mentioned in my presentation, in the end of the day, the most important thing is to perform an oncological, R0 resection on oncologically well done, well performed operation, which with the robot, when you cannot feel the tissue, you cannot feel like whether there's a hard tissue or a soft tissue, whether there's a lymph node visible or not, it's very difficult to perform better rather than the open surgery. And I think this is the main disadvantage. People are trying, but as every new thing, when you're trying, your outcomes will always be worse than something that is already set up and distinguished. Like when you even in the robotic prostatectomies, they're not going in a very advanced robotic prostatectomies. If they need to perform, like for example, the colleagues in St. Mark's or down in Guy St. Thomas's in central London, they will do an open prostatectomy if they think that prostate will not be the only organ that they need to remove. So in order to give the patients the best possible outcome, is you just need to do something that you're feeling proficient in.
Great, thank you. So, guys, that would be all for tonight. Danko, thank you once again. It was a really great presentation, and thank you for all your answers. Just a second. Okay, so guys, thank you all for being here with us in our webinar, and we would like to invite you to the second webinar with the topic Cancer Nurses and Psychological Distress, which is going to be on November 27 at the same time, and here at the Zoom platform. We also send you in the Q&A to fill a survey, which you will receive in a few days. It really means a lot for us. And thank you once again. And have a nice evening. Enjoy. Bye.
Selma, we have somebody who raised the hand.
Oh, I'm sorry.
Is Ia? Somebody has raised the hand. If they want to ask any question.
I don't see it, honestly.
I can see the raised hand. I'm not sure if it's a question or if it's a goodbye or something, but it's Ia. Do you want to ask anything? No? Okay. I think probably it was just a goodbye. Thank you everyone for joining. Thank you so much for joining us. Thank you. See you on the 27th then. Thank you. Bye-bye.
Bye.